Hello everyone, I'm Dr. Lahari here and welcome to this lecture on radiographic appearances of cysts, tumors and fibro-osseous lesions of the oral cavity. The learning outcomes would be dealt separately for each of these topics. To begin with, classify the odontogenic and non-odontogenic cysts, describe radiographic features of odontogenic and non-odontogenic cysts, understand the radiographic differentiating features of odontogenic and non-odontogenic cysts. A true cyst is a pathologic cavity in bone. It is lined by epithelium and may contain a small amount of fluid drawn from adjacent cells and tissues. The epithelium may be derived from odontogenic or non-odontogenic sources. Clinical features of cysts of the bone. The most common clinical features is a firm to bony hard swelling that may be accompanied by pain if the cyst is related to a tooth with a non-vital pulp or has become secondarily infected. So this is something very important to realize, that many a times in the clinical scenario in a dental setting, patient who comes to us with an odontogenic cyst often realizes that there is a cyst because of this bony hard swelling, more likely, rather than pain. So pain only arises later if a tooth becomes non-vital or if the cyst itself becomes secondarily infected. The applied diagnostic imaging is important. It has roles in assessment and management of a cyst in the bone. First, imaging may aid in the initial diagnosis of a cyst and may describe its extent within the bone. Radiologic investigations may also help to determine the extent of extraosseous involvement, that is, involvement other than the bone into the soft tissue, and assist in determining the best site for biopsy. So, imaging features, like any other radiographic appearance, would primarily involve the location of the cyst, periphery, shape, its internal structure, and its effect on the surrounding structures and adjacent teeth. The image here is showing us the cyst, which is small in size initially, and the tooth you can see is discolored, and as it is growing it has actually displaced the adjacent inferior alveolar canal. Let's start off with the simplest and most commonest cyst of the jaw, which is the radicular cyst, generally caused by inflammatory condition like dental caries or tooth which is involving the pulp because of other reasons. In this radiograph here, A and B, you were able to make out that there is a very well-defined radiolucency around the apex of a tooth. Generally, the PDL and the lamina dura are lost, and the cyst is originating from the root apices of an infected tooth. Right, so this is the same a similar radiograph where you can see the enlargement on the occlusal view in the buccolingual direction. So that is exactly how the cystic space looks like, and there is a thin rim of sclerotic margin covering the well-defined radiolucency. Next, let's discuss the incisive foramen cyst, or also called as a nasopalatine duct cyst. And let's look at the differences between what is a normal incisive foramen and a cyst in that area. Generally, a normal incisive foramen is less than 5 mm in diameter, the one you can see in the picture over here. Anything larger than that is considered to be a pathology and must be investigated and suspected of a nasopalatine duct cyst. In this image here, you can see a very large cyst in the maxillary anterior region with a nice sclerotic margin. Nasopalatine duct cyst is actually a soft tissue cyst which involves the bone and creates a radiolucency in the maxillary anterior region, typically arising from the incisive foramen area. Next is the lateral periodontal cyst. This is a cyst that arises generally in the periodontium or the periodontal ligament space and located between the roots of two teeth. This is an example of a lateral periodontal cyst, which is showing a well-defined radiolucency in between the canine premolar region of the maxilla. A lateral radicular cyst is also a radicular cyst and shouldn't be confused for a lateral periodontal cyst. This happens when a cyst forms along a non-vital tooth and generally involves the accessory canals. And hence, even in a lateral radicular cyst or a lateral periodontal cyst, it's important to check the vitality of the tooth to ascertain that it is of pulpal origin and not periodontal in origin. A residual cyst is a term given to a cyst that is left within after post extraction, and if the cystic space has not been surgically debrided. Now, this is the reason why I stress again and again that even if there's a root stump, it's important to take a radiograph before extraction is performed. This is to avoid the chances of missing a periapical pathology and leaving behind such a cystic area, which in future could lead to getting secondary infected or probably lead to pain, or in case you would want to place an implant in that area, it becomes an issue because you have discovered on the radiograph that there is a residual cystic area, and that you would have to go back in time and go back in and debride the area and perhaps um, look for bone harvesting and grafting. Next is the most one of the most commonest cysts in the jaws is the dentigerous cyst, generally arising from the neck of a tooth. And again, I would like you to understand that radiolucency around a normally impacted tooth, which is less than 5 mm, could be a hyperplastic dental follicle. Generally, the dental follicle covers all impacted teeth, and usually the size of diameter of the follicle or the size of the follicle from the edge of the follicle to the edge of the crown is just about 1 to 2 mm. It can even be considered as a hyperplastic follicle or a bigger size follicle when it's less than 5 mm. But anything beyond 5 mm in diameter, that means from the edge of the radiolucency to the crown, if it's more than 5 mm in diameter, you must suspect a dentigerous cyst. In this case, you can see that the third molars are having dentigerous cysts, especially typically arising from the neck of the tooth. The dentigerous cyst, the differential diagnosis would involve an odontogenic keratocyst or even a unicystic ameloblastoma. Both of these lesions also can look very similar to dentigerous cysts, either in the third molar region or the maxillary canine region, which are all favorable sites, sites of predilection for both the dentigerous cyst as well as the OKC and unicystic ameloblastoma. OKC, typically multilocular lesion. There are multiple locules with septae separating them. And in this particular radiograph, you can see that it's a wide lesion, about 5 cm in size. There's involvement of the mandibular canal at the closer to and the lesion is very close to the lower border of the mandible. There is resorption of quite a number of teeth, and it shows how aggressive the OKC or odontogenic keratocyst is. When multiple odontogenic keratocysts are suspected, then it is important to rule out basal cell nevoid syndrome, also called as Gorlin syndrome. In this particular case, you can see that there are multiple cysts in regions of the maxillary, very close to the maxillary sinus. There's one cyst up here in the lateral maxillary lateral incisor and canine region, and there is one in the ramus with an impacted tooth. This one is in the body of the mandible, doesn't have an impacted tooth, as well as number 5, which is in again in the third molar ramus and body region having an impacted tooth. So OKCs need not have impacted teeth always within them. They can also arise in the odontogenic region without association with teeth, but very close to the odontogenic region. And when multiple such OKCs are suspected, it's important to rule out basal cell nevoid syndrome. Calcifying odontogenic cyst. These cysts are not very common though, but they generally involve the mandible, can be seen in the anterior region as well as the posterior region of the jaw, and there is certain calcification which can be seen within the cystic cavity. And so when you see these specks of radioopacity within the cystic cavity in a unilocular or uniformly defined radiolucency, it's important to suspect a calcifying odontogenic cyst as part of the differential diagnosis. Now moving on to radiographic appearances of tumors of the oral cavity. The learning outcomes would be to classify odontogenic and non-odontogenic tumors, to describe radiographic features of both of these, and to understand radiographic differentiating features of both of these kinds of tumors. A benign neoplasm is an abnormal mass of tissue that develops as a result of uncontrolled cell proliferation. A tumor is a more generic term that refers to a tissue mass. So, while all neoplasms are tumors, not all tumors are neoplasms. Benign neoplasms may be found incidentally on a radiographic examination made for other purposes, or they may be detected clinically by an enlargement of the jaw or movement of the teeth. So, like we discussed with the cysts, many a time pain is not the primary manifestation or clinical feature that is seen in a patient with an odontogenic tumor. So, it's important to understand that tumors in the jawbone have insidious onset, are slow growing, are painless, and can be locally aggressive if they actually extend into the adjacent tissue spaces. A benign lesion is shown in this image, which is growing concentrically in the bone. They can be round, oval, or lobulated. As they grow, benign lesions can displace adjacent bone borders, teeth, and also externally resorb tooth roots. So, this is something very important that we look for when we are looking at any radiographic image of a tumor. This is the WHO classification of odontogenic tumors, and we would be covering most of these in the next few slides. So let's start off with something which is not a tumor. This is an example of an idiopathic osteosclerosis, generally seen in the odontogenic region, may be associated or closely attached to a tooth or slightly away from the tooth. The differential diagnosis would be condensing osteitis or inostosis, but in this case, you can see that the lamina dura is intact for this molar, and the molar doesn't seem to be having any pulp involvement, and hence this is an idiopathic osteosclerosis. Absolutely benign and can be left the way it is and need not receive treatment. This is an example of a cementoma, a large radiopacity, irregularly defined with having a radiolucent rim around it and surrounding the roots of the molar here. And in this case, the molar along with the entire lesion must be surgically excised. And you can see that the radiopacity is actually very closely involving the mandibular canal. On the other hand, cementoblastoma, very closely related histopathologically to a cementoma. This is an example on the radiograph where you can see mixed radio-opacity associated with the effects of a tooth. You must understand that both cementoblastoma are generally arising from the cemental region, and it is surrounded by a larger radiolucency, quite mixed in appearance, and differential diagnosis of cementoma as well as hypercementosis must be kept in mind. This is hypercementosis, generally seen in teeth which are weight bearing and have adjacent teeth which are missing. The cementum appears to be thickened and widened, and it appears to be fusing with the cementum completely. You can't really make out the enlarged area, and it is just excessive amount of cementum deposition that is visible on the radiograph attached to the root apex. Compound and complex odontomas. Compound odontomas are very similar. They can be multiple, impacted, or can erupt into the oral cavity as well. Compound odontomas can be very similar to tooth-like structures, and some of them might even contain, you would be able to differentiate on the radiograph with enamel, dentine, and pulp within the odontome itself. Whereas complex odontomas are irregular and do not really have a shape. They're just masses of depositions which can be it's very difficult to make out where the enamel, dentine, and pulp are. So these are both cases of impacted compound and complex orontomas. Bear in mind that these can cause impaction of the teeth, and when present, for example, in this case, there's an impacted canine here, and the complex orontoma is obstructing the path of eruption of the canine. Amyloblastoma. The multiple, we've just seen an example of a unicystic amyloblastoma, which can look very much like a dentigerous cyst. The multilocular variant is generally given the soap bubble appearance, and it's a very classical appearance of the amyloblastoma, where you can see multiple locules. Again, this lesion is quite extensive, in size about 5 cm in diameter, in and times 3 cm, and it's involving the lower border, the mandibular canal, very close to the lower border of the mandible. Adenomatoid odontogenic tumor, also called as AOT. Classical area of involvement is the maxillary canine region. You would see that the radiolucency surrounds the canine with multiple small tiny radiopaque flecks seen within the well-defined radiolucent area. This is an adenomatoid odontogenic tumor. The calcifying epithelial odontogenic tumor, CEOT, also has the appearance of what is called as a driven snow. It is appears mixed radiopaque and radiolucent, and not clearly defined or demarcated areas, and can generally involve the posterior mandible. Can appear sometimes like a mixed appearance, where you're seeing a lot of opacification and locule-like areas, but the locules are not as defined as a multilocular radiolucency. These appear more ill-defined, and hence the appearance of driven snow. Osteoma is a tumor arising from the bone. These could be, they are benign, and they could be osteoid osteomas or peripheral osteomas. Generally, the mandible is involved. The osteoid osteoma is within the body of the mandible, and the peripheral osteoma generally extends out of the body of the mandible, or the lower border of mandible is one of the most favorite sites for an osteoma. Exostosis, these are actually not tumors, they are hematomas. This is example of mandibular bilateral bony exostosis. They can also be seen in as buccal exostosis in the maxilla as well. Osteochondroma, this is just an example of how there's an enlargement of the condyle of the TMJ, and again, not very common, but arising from the TMJ, the coronoid condylar process, and this is how it appears on the radiograph. Large radio opacity, which is having well-defined borders. Now that we've looked at the tumors and cysts, let's look at malignancies of the jaws. Radiologic features of malignancies of the jaws. When we're talking about diagnosing malignancy based on the radiograph, it is important to understand that it would be very difficult for you to suspect the type of radio or type of malignancy. But it's important. What is important to understand is that the manifestations of malignancies in the jaws, and how they look different from benign lesions, and what is important to look at. So, when we're talking about that, it is important to keep in mind that radiologic features of malignancies can either manifest as ill defined invasive borders, lesions with borders which are ill defined, destruction of cortical boundary with adjacent soft tissue mass could be there. There could be irregular thickening of the PDL due to the invasion, for example, the one seen here. And they could be multifocal lesions, like multiple of them involving the bone. There could be effects on cortical bone or the periosteal reaction, which is an example of the onion peel appearance, or a Codman's triangle, or a sunburst appearance, and also the appearance of teeth floating in space, which happens because of extensive destruction of the bone and a large radiolucent defect left inside the jawbone. So essentially, these are methods, these are ways in which the malignancy manifests in the jaws. But again, I'm pointing out and reminding you that it's impossible, virtually impossible to tell, suspect what type of malignancy it is histologically. So what we've seen was diagrammatic representation. On the radiograph per se, what you could see, for example, on a CT scan would be break in cortical margins with irregular appearance of the radiolucency, or soft tissue mass, which is seen with a bone involvement and ill-defined radiolucency, like the one seen around the molar. You could also see irregular radio opacities, which are ill defined and very dense in appearance, and also masses which are completely involving the maxillary sinus and giving an irregular appearance with not uniform density, which all are suspicious of malignancies of the jaws. Even if it is having there is a metastatic carcinoma to the jaw, it is again very difficult to differentiate what type of metastasis it is, or is it a primary tumor of the jaw, or is it a metastatic carcinoma. They would appear on similar lines to any malignancy in the jaw, with ill-defined radiolucencies and no obvious dental causes, or appearance with periosteal reaction of the bone, and cortical bone having ill-defined radio opacifications, which do not look benign. This is an example of osteosarcoma with the sun ray appearance, or is also called a sunburst appearance, which is a periosteal reaction. And osteosarcoma is a very aggressive malignancy of the jaw, and this is the appearance pointed out by the white arrow marks. Langerhans cysticercosis, I've just cited this example over here. Though clinically, this is the manifestation of the lesion on the radiograph. Again, it's very difficult to differentiate between periodontitis. It can pass off as a chronic periodontitis if you weren't correlating it with clinical features, and hence the malignancy gives the appearance of ill-defined radiolucency and a lot of bone loss. Like I told you, there are multiple factors that go into diagnosis of malignancies of the jaws. Clinical features, histological features, and radiographic features combined together should help in arriving at a diagnosis. Radiographic appearances of fibro-osseous lesions. This is the third part of this lecture series. The learning outcomes would be to classify fibro-osseous lesions, to discuss their radiologic features, and also the differential diagnosis. Bone is actually a complex tissue, as are the mechanisms that regulates its structure and function. Metabolic diseases can alter normal bone structure, although the nature of the changes seen in imaging may appear similar between different disease entities. Coordination of the activities of the bone forming, that is osteoblastic activity, bone maintaining, osteocytic activity, and bone removing, that is osteoclastic activity, all of these cells regulate the normal structure of bone in the skeleton. When it comes to bone dysplasia, these include a group of conditions in which normal bone is replaced with fibrous connective tissue and abnormal immature bone. Histologically, the term used is called as fibro-osseous lesions. So, it has been hypothesized that osteoblast and osteoclast function becomes dysregulated, favoring one cell type's activity over the other. It is important to understand, in the context of bone, the term dysplasia actually does not imply it's a pre-malignant condition or a process. Bone dysplasias are not neoplasms and therefore should not be managed like a neoplasm. This is a diagrammatic representation of the dysplastic lesion of the bone that alter the normal bone architecture. Normal bone is replaced by fibrous connective tissue and numerous short, irregular shaped trabeculae. So the most common is fibro-osseous lesions that we generally describe is the fibrous dysplasia, and these images give you the appearance of orange peel appearance. That is what is called in radiology terminology, where you see the trabecular pattern strikingly different from the adjacent normal trabecular pattern in this first molar, whereas the second mandibular molar's bone surrounding it shows you ill-defined, thinned out trabeculae, very similar to that of an orange peel appearance. So clinically, you would be able to see that there is bony swelling and enlargement on either one or few areas of the bone. Again, another appearance of fibrous dysplasia. This is more like a ground glass appearance, ground glass appearance involving the entire maxillary sinus and maxilla. On the radiograph, on the CT scan, also shows large radio opacity, and this is what is called as ground glass. That means glass which is not transparent but appears hazy. Fibrous dysplasia can also manifest as a fingerprint appearance. This is what we're discussing about the fingerprint appearance or seen in the mandible. And in this particular case, two areas in the mandible are showing similar kind of appearance of fibrous dysplasia. Periapical cemental dysplasia is a disease involving primarily starting off at the cementum and predilection for lower anteriors. This disease has three stages to it, stage 1 to 3, and as the lesion progresses from stage 1 to 3, it starts off as radiolucent area with ill-defined margins, then moves on to a mixed radiolucent radiopaque appearance, and then finally there is excessive amount of radio opacity. Now, the progress from stage 1 to stage 3 can take quite a few years to happen, and generally the teeth are vital and the patient is asymptomatic. So, I've also listed out here the differential diagnosis based on the appearance. This could be the rarefying osteitis could have been thought of as a differential diagnosis for stage 1. For stage 2, with mixed appearing lesions, condensing osteitis can be thought of as a differential diagnosis. And for stage 3, where there is a radiolucent periphery around the radiopacity, a benign cementoblastoma or even the presence of an odontome attached to the apex of a tooth can be thought of as differential diagnosis. Focal cemento-osseous dysplasia is the terminology used when similar periapical cemental dysplasia is seen in the molar region. Also, the appearance is very similar to the previous case with the differential diagnosis of benign cementoblastoma or dense bone island. Irregular radiopacity with a rim of radiolucency seen very close to the periapex of teeth. The term florid cementoosseous dysplasia, also called as gigantiform cementoma or familial multiple cementomas, is given to the appearance where there are multiple areas of opacification seen. Again, this can be involving multiple teeth of the jaws. The differential diagnosis would be Paget's disease or chronic sclerosing osteomyelitis. Cemento-ossifying fibroma or also ossifying fibroma or cementifying fibroma. This is generally gives the appearance of mixed radiopaque radiolucent appearance with multilocular appearance as well. There is expansion of the jaw in the buccolingual direction and could be anterior posterior direction as well. And it is a bony hard swelling generally, and this is the appearance of the opacification seen in the jaws. The cemento-ossifying fibroma could also have a peripheral component to it with enlargement into the oral cavity. And when this happens, you could have a differential diagnosis of fibrous dysplasia, periapical cemental dysplasia if the area is small, or central giant cell granuloma, or a COC or a CEOT. This is example of a central giant cell granuloma. This is a reactive lesion, and you would see that there is enlargement of the jaw in this patient here, where you can see that the chin area is showing a swelling. And when you look at it intraorally, there is vestibular obliteration. On the occlusal view, you can see that there is an ill-defined mixed radiolucent radiopaque appearance involving considerable area, right from the lateral incisor to the central incisor to the molar region, and a large radiolucency seen in the panoramic radiograph. Generally, central giant cell granuloma is a lesion which is seen anterior to the premolar region, and it can cross the midline. Cherubism, again, rare, but possibility that you would have multiple bone involvement. Maxilla and mandible can be involved, multilocular appearance, and you would feel that the teeth are floating in the multilocular appearance, hard bony swellings with a long-term treatment plan and for the patient who has this condition.
Paget's disease, also called as osteitis deformans, it's a skeletal disorder involving osteoclast resulting in an abnormal deposition and resorption of bones. You generally see osteolytic lesions, which could be seen on the skull over here, called as osteoporosis circumscripta. In advanced stages, the term cotton wool appearance is used where the entire skull or the jaw involved, bone involved appears like whitish because of the radio opacity and excessive abnormal deposition or resorption of bone. So that brings me to the end of this chapter. I have given you examples of different types of radiographic appearances seen in the bone, and the diseases that we've covered are just few examples. For more information and in-depth reading, I would suggest that you go through the textbook and look through the examples. And it's very important, as I keep on reinforcing and making it clear, that to understand and to retain radiology, it's very important that you keep looking at images which your eyes recognize, and it's easier for you to compare it to something which is abnormal or something which is normal, and that's how you retain the information that you and that's how you learn and interpret and practice radiology. Thank you very much. If you do still have any doubts, kindly feel free to contact me.